I'm Dr. Howard Elkin. I'm a cardiologist, and I went to medical school at Medical College of Virginia. I did my internship and residency at Michael Reese Medical Center in Chicago. I did my cardiology fellowship at Northwestern University in Chicago. And then I did an additional year of invasive cardiology in Los Angeles at the LA Heart Institute. I was trained as an invasive interventional cardiologist. But by around the mid-1990s, I really kind of changed my focus to prevention because I was seeing the same patients over and over again. You know, the gunky artery syndrome, same patients came back, and I realized that coronary disease is a disease of excess. Excess cholesterol, excess fat in the diet, excess smoking, excess stress, and a lack of one thing, physical exercise. And I was seeing the same patients recurrently, even if I did an angioplasty or a stent, or even if they went for open heart surgery. So many of them were back within 2 or 3 years with repeated events requiring additional interventions. I said, this is not the way to go. So I was seeing the same patients over and over again, and I had a keen interest in prevention to begin with. And then I learned about EECP as an alternative modality for medical treatment of coronary disease, and I was instantly turned on to it. And I purchased a machine, and that was in 2001, and I've been doing it ever since. And I've had remarkably good success with so many of my patients, especially patients with chronic angina. It really has been extremely useful there. One of the great things about EECP is, first of all, it's completely non-interventional. And it's been shown in repeated studies that medical therapy is as good as interventional therapy when it comes to chronic stable angina. And that's really what I see most in my practice, people with chronic stable angina. So if medical therapy is as good as intervention, then why would we always go into interventional therapy? And I consider EECP as the Mercedes-Benz, so to speak, of medical therapy because it's not pharmaceutical. It's mechanical. It's an external mechanical process. So it has absolutely no side effects as opposed to medication. So, and I've seen great success in that. People always ask, well, how does it work? Is it magic? Is it really, what really happens? And, we don't know everything about it, but what we do know is that it does build collateral vessels, and it works on the second phase of the cardiac cycle. There are two phases: the first phase, and the second phase. The second phase is when the coronary arteries fill, and when the heart actually relaxes, and that's called diastole, and that's when EECP works. It actually takes twice as much energy for the heart to relax as it does for it to contract. And so by increasing the pressure and the flow of blood from the extremities forward to the heart over a period of several weeks, new blood vessels form. It's like what I call mini bypasses, what I explain to my patients. And that's really collateral flow. Everybody's heard about collateral flow with exercise. Exercise does improve collateral flow. That's one of its many benefits. Well, EECP does it too, but I would say it does it faster than exercise. And the two together are an excellent combination. Since I've been doing EECP regularly, since 2001, I've seen numerous benefits. Most important was decreased chest pain. People can do more with less effort, and that's really the purpose of medical therapy. So here we're doing it without medication, or oftentimes I'm actually able to lower the doses of medicines or decrease medicines, sometimes stop them completely. So people are able to do more with less angina. It also improves the quality of their life, and it also improves the heart function. So people can do more with less effort. There's less shortness of breath. Some other offshoots, it's not indicated but I've also seen that improves mental clarity because we're also increasing blood flow to the brain. And it's really good for people with peripheral artery disease because it increases blood flow to the lower extremities. So although it's not indicated for those particular conditions, they're very common in the elderly population. Yes, stents and bypass is I like to do it for patients that present with very unstable conditions, and which has been shown unequivocally to improve life, to improve longevity, and also to improve symptoms. But most of what I see is really of the chronic basis, and I see so many patients going in for stents in their 80s and 90s, which is ridiculous, because the complication rate is not small. I mean, it really can happen. I've seen people have perforations in the arteries, dissections, and things like that. It's a lot to put someone through with that age. Again, if it's an acute emergency, it's one thing, but a lot of these patients that have lived that long have chronic symptoms. They are the perfect candidates for EECP. Also, I've had patients that have had 2 and 3 bypasses. I've had a patient that's had 31 angiograms between his heart and his lower extremities. He has more stents than I can count. And I routinely put him through a series of EECP treatments whenever he becomes symptomatic, which is usually about once a year. Because really, I don't think at 85 he could undergo another bypass surgery, and he's been stented to the nth degree. So these are just perfect situations in which EECP, I feel, is just the therapy of choice. We also have to look at patients with comorbid conditions, and we tend to think of that as those in the elderly age group, but really we see a lot of people with hypertension. Diabetes is a big one. If you just look at diabetes, type 2 diabetes, 70% of these patients will have a heart attack or a stroke in their lifetime. I mean, you can just bet that's the statistics. So these are the patients with these comorbid conditions with multiple problems, and they may have respiratory problems, COPD, emphysema, asthma, so forth and so on. They are high-risk patients to go through stenting and bypass graft surgery. I mean, it really is, you're putting them through a lot, whereas ECP is so well tolerated. I mean, it really, in all my years of doing it, I mean, I've never seen any major complications. It's so easy, so it's really ideal for those that have a lot of different comorbidities. Obesity, which is a risk factor in itself. Again, hypertension, hypertensive heart disease, and clearly diabetes. And peripheral vascular disease. I mean, all these patients are very ill, potentially ill, and can really benefit from EECP. But I know from many years' experience that what I'm doing is good because patients are happy, they become compliant, you get them more involved with their therapy, and they feel good. What could be better than that?